Hello and good day to everyone. Welcome to the fourth International Virtual Symposium of Group Insert. My name is Ivan Montes, and today we're going to talk about intrauterine insemination. It's a pleasure to have you here, to all of you. So, when we talk about IUI, which is intrauterine insemination, and I will refer to it through the whole presentation as IUI, we can talk about two models of treatment. The first one is when you use the sperm of the couple of the woman. The other is when you use a donor semen and you do the IUI with the donor semen. So as a definition, the IUI, it's a reproduction technique. And it's very important that we understand what does it mean, because actually you need to do something through the whole process to use this technique. And the objective of this technique is to deposit in a non-natural way a sperm in the female reproductive system. And always it's important to understand that it should be coordinated with the ovulation of your patient. We have some requirements to do it. The first one is that we have to check the tubal factor and detect or determine the patient fallopian, the fallopian tubes that are patent in the patient. This, we can do it by two ways. One is with the hysterosalpingography, or the other one in case that you need to do anything else, or there might be another diagnosis, and in that way that you need to do something else to your patient, you can do a laparoscopic surgery and determine the patent fallopian tubes of your patient. The second one is the uterine factor, and you need to check that the uterine cavity is normal. To do this, you can use the transvaginal ultrasound, also the hysterosonogram, or preferably you can use the hysteroscopy to check that the uterine cavity is completely normal, that you don't have polyps, myomas, or septums. And when we decide to do the IUI, the most common cause to do this is when you have a male factor. And why is it important to know this? Because 20% of infertility cases in the world are due to male factor. And when you want to do an IUI, you have to know that the IUI is effective for male factor. And how do you describe this? And there are two ways to do it. One is when you have a total motile count of more than 5 to 10 millions of sperms, because sometimes when you receive the spermogram, you see that the volume of the ejaculation is normal, but maybe the number of sperms might be closer to normal or below the normal levels. But you have a good motility and you have a good morphology. Or sometimes you have a good number of sperms, but low motility and good morphology, or in other cases, good motility, but not that good the number of normal sperms. So one way to decide when to do it or when not to do it, it's with this number that is called total motile count. And if you have more than 5 to 10 millions, the results of the IUI might be better than when you have less than 5 millions. And another way to do it is when you do a post-wash sperm count and you have more than 1 million, then you can do an IUI. The DNA fragmentation index is something that we've been using for later years, where 30% above 30% is considered abnormal. But when you want to do an IUI, there are no differences in the pregnancy rates when you have a DNA fermentation index above or below 30%. It's also important to note that when you have a patient that is 40 years of age or above, the risk of complications during pregnancy or after the pregnancy increases, especially related to preterm birth, spontaneous abortion, autism spectrum disorders, and infertility. And also, when you have a paternal BMI below 25, there's also a significant decrease in semen parameters. So usually when you have one of these two types of patients, you can recommend the IUI, but only if the TMC is above 5 to 10 million of sperms motor. Related to the female factor, 30 to 35% of patients with infertility are solely female factor. The rest is a combination between both. So in patients where you think that the factor of infertility might be female, you have to know that one of the most important things that we need to know is the age of the patient. Because the result of the IUI will be completely different if we have a patient of 25 or 36 or 40 years of age. And as you can see on the graphic on the right side, this is the percentage of success per insemination. And when you have a patient of 25 to 30, 35 years or almost 36, you can see that the live birth is above 10%. But when the patient is above 39, the percentage of live birth rate decreases. Also happens the same thing with pregnancy rate, where it decreases also with the age, and the miscarriage rate increases with age. So actually, when we have a patient and we're seeing the female factor and we're doing the diagnosis, the first thing that we need to do is cross a line. And that line will decide if she is able to do an IUI treatment or if she isn't. If she's above 38 years of age, we recommend that you do not do an IUI, but decide to do another type of treatment. It would be better to do an in vitro fertilization treatment. The second thing is the body mass index. The patients with higher body mass index need have more medication requirements than patients that are with BMI normal. And there's an advantage in this type of patients that when you see a patient with a higher BMI or a normal BMI, there are no difference in conceiving related to the cycles, the cumulative pregnancy rate or multiple pregnancy rates. But the thing is that you might need more dosage or sometimes even more timing of the medication for patients with BMI above 25. And the third thing is the ovarian reserve, where you can do this type of treatment, the IUI, you can do it in patients with ovulatory dysfunction, especially in PCOS patients. But when you have patients with low ovarian reserve or the origin of the anovulation is hypothalamic, the results are below 5%. So we do not recommend to do in the patients with anovulation result from hypothalamic causes or from low ovarian reserve. So in which patients would you do this type of treatment? We recommend 3 types. First, again, mild male factor. When we have a TMC above 5 to 10 million of sperms or a post-wash sperm count above 1 million, you can do it. We actually recommend higher levels, but in the literature, those are the numbers that they say that below 1 million after the post-wash, the results are below 5%. Above, it can be almost like 8 to 10, almost to 15 or 20%. In cases of female factor, when the cause is ovulatory dysfunction or when you have endometriosis. But it would be better if you do the IUI in patients where the endometriosis is diagnosed on stage 1 or 2, where the cumulative pregnancy rate can be as high. Sorry, the pregnancy rate per cycle can be as high as 22 to 25%, versus patients who are in the stage 3 or 4 of endometriosis, the result might be below 5.6% per cycle of treatment. And also in patients with unexplained infertility, where the cumulative pregnancy rate is around 57% after 3 cycles. So when you need to decide which type of treatment you want to do with your patient during the IUI, you need to decide which medication you're going to use. And that's one of the most frequent questions that we have. Should I use clomiphene? Should I use gonadotropins? Or should I use letrozole? So I wanted to bring you a study. This study is from 2017, where they compared two groups, one with clomiphene and gonadotropins, the other one with letrozole and gonadotropins. The age, duration of infertility, BMI, the endometrial thickness, they're all very similar. But there's a huge difference between the clomiphene and the letrozole. You know that the clomiphene belongs to a group where there's a modulator of the estradiol receptors, and it has a positive effect in the brain related to the stimulation of the ovaries, but it has a negative effect in the endometrium and also in the cervical mucus, which means that patients with clomiphene might have lower thickness of the endometrium compared with letrozole. Another difference is that clomiphene can produce the multifollicular stimulation, different from letrozole, where you stimulate just one, might be two when you use the gonadotropins. So actually, when you use letrozole, patients with letrozole have better endometriums, better thickness in the endometrium of those patients before the HCG injection. And also, because the endometrium looks better, the pregnancy rates are higher than when you compare them with clomiphene. Also, because you stimulate more than one in the clomiphene group, there is a higher risk of OHSS, which means that there are higher risk of having to cancel these type of patients. And also something that was very similar is the number of cancel cycles related to the non-formation of two follicles of 16 millimeters in this study, which was very similar in both groups. So you think that with the clomiphene, you might have more chances of having the patient stimulated or with the follicles as you want. But in the patients with letrozole, actually, for us, it's safer to use it. And I haven't done a cycle with clomiphene in like 5, maybe 7 years, so I would recommend the letrozole. There's another study. This one is from China. It's in fertility and sterility, 2018, where they compared the three groups: clomiphene, letrozole, and gonadotropins. And as you can see, the clinical pregnancy of clomiphene, letrozole are similar than the gonadotropins, where it's higher in this type of patients. And the risks of having twin pregnancies are very high in the clomiphene group, different from the letrozole. And also with the gonadotropins, the risk of having twin pregnancies increases, which means that actually, if you don't have a lot of tools to do this, and you just have one or two tools, one of those might be the letrozole. The use of letrozole helps you have the confidence to stimulate the patient without knowing that you won't have more than 3 or 4 follicles during the process of stimulation. And how we recommend the protocol? If you're going to use clomiphene citrate, we recommend that you use it when the menstrual period comes. You do the first ultrasound. And this would be the second tool that I would recommend, because you need to know how many follicles you're going to stimulate at the beginning and also during the process of stimulation. Because usually when we have multiple pregnancies of high order, these pregnancies happen in patients where they were not followed up, where they were not, they were not followed with the ultrasound. So we recommend that you do the follow-up with the ultrasound. That this is one of the most important tools that you will have in your office to stimulate patients and to do the IUI. So we recommend 3 different types of protocols, but also you can mix them. So when you use clomiphene, citrate, or letrozole, we recommend that you start on the second day of the menstrual period and use it for 5 days and no longer than 5 days. Also, the same with the letrozole. But the gonadotropins, you know that you will need more gonadotropins, because when you stimulate for just 5 days, you won't have a dominant follicle, so you need more days. Usually, the normal patient, the ambulatory patient, takes around 10 to 14 days to respond to the gonadotropins. We recommend also that you start with the lower dosage possible. So we recommend a dosage of 37.5 units per day. And on that cycle, you should use the same dosage through the whole cycle. If the patient doesn't respond, the next cycle, you can start with a higher dosage, but not higher than 50% of the previous dosage, which means that if you used in your previous cycle 37.5, then on the second cycle, you can start with 50 units. Don't start with 75 units, because it might be a lot. And you know that especially in patients with PCOS, that the threshold to stimulate one or stimulate a lot is very, very, very thin. So you can have a completely different response with a small increase in the dosage. So this is very important. Also, when you do the IUI and you have a preovulatory follicle, that we would recommend that you measure at least 2 different measures, and you have a follicle above 18 millimeters of diameter. On that day, you can do the trigger. And we recommend that you use recombinant HCG or urinary HCG. It doesn't matter, because both of them respond very well, especially in this type of treatment, which is IUI. And 36 hours after the trigger, you should do the insemination. And always use progesterone in the luteal phase. The pregnancy test should be done 2 weeks after the test. Another question that we have a lot is, how many follicles should I see or stimulate or think about having them above 18 millimeters to do the trigger, and when should I cancel? And this is another study. I'm sorry I didn't brought the date, but this is from 2016, I think. This one, it's also very, very fun, because this one measures the multiple pregnancy rates according to the follicle number, the stimulation days, and the estradiol levels. So usually when you do IUI with the couple or donated, the results are almost the same, but a little bit higher in the donation process. Why this happened, we're not completely sure, but this might be related to the thing that the patient that uses a donor usually doesn't have a diagnosis of a female factor, which means that the pregnancy rates per cycle might be higher than in patients where they have a female factor that might be causing the infertility. But the pregnancy rates are very similar. When you have a follicle of one follicle, usually the multiple pregnancy rates are below 20%, and when you have more than 2, well, it increases, and when you have more than 5, it increases a lot. And the thing is that usually when you have multiple pregnancies, when you have more than 4, are usually triplets or four, and that's a very high risk pregnancy. So we recommend that you cancel the cycles when you have more than 3 follicles above 18 millimeters. The stimulation length in days, well, it depends. Usually, when you have less than 5 days of stimulation, the pregnancy rates, the multiple pregnancy rates are below 20%, but also the endometrium might not be ready, especially if you use clomiphene citrate. So we recommend that you go with at least 7 to 10 days, although it might increase the risk of having multiple pregnancies. And also, if you have the possibility, you have the chances to measure the levels of estradiol before you do the trigger. Levels above 1,000 increases the risk of multiple pregnancy more than 20%. So we recommend that if you have the chances of doing the test, you should do it and read the test and decide if you prefer to cancel, or if you have more than 3 follicles, then you should also cancel. One recommendation that we also give to our doctors or doctors or specialists that work with us is that this type of treatment, you can schedule the IUI according to your agenda. This is not something that you must do at 10 p.m. on Friday. No, you can schedule this. And how you do it? We know that the ovulation process happens after 36 hours after the LH peak, the beginning of the LH peak, which means that if you trigger a patient with a follicle of 18 millimeters, 36 hours later, she will ovulate. Between 36 to 48 hours later, she will ovulate. So you can schedule this according to your agenda. You can decide if you prefer to do it maybe on a Monday, so you can trigger her on a Saturday night, or maybe you can wait another day and just do the trigger on a Sunday to do the IUI on a Tuesday. So it depends on you. Okay, it should depend on you, and you know that when you do the insemination before the ovulation, the pregnancy rates are higher than when the IUI is done after the ovulation. So you should also know this, because sometimes we've seen it before that they do the trigger maybe 48, 72 hours before, and they do it, then they do the IUI. And we know that that patient will not get pregnant on that cycle. So that's one of the recommendations. Also, you can decide not to use any trigger like HCG, but the thing is that you will not know when that patient will ovulate. So you should do, in a natural cycle, the IUI after 24 hours after the LH surge. So you should do LH tests, urinary tests, or blood tests to check the LH levels, and if are above 15, you should do the IUI. But this is very difficult, and sometimes in that type of patients, that's when you have to do it at any moment. So we recommend that you schedule the IUI according to your agenda. Another thing that also we've seen a lot, it's that on the same cycle they do a double IUI. For example, we do the trigger today, maybe a Monday, and we do an IUI Tuesday morning and Wednesday morning. And the studies haven't showed a difference in the pregnancy rates when you do a double IUI. And it's difficult for the patients, difficult for the couple's patients, and sometimes even difficult for you, for your agenda. So we do not recommend also to do a double IUI per cycle. Another question that we always have when we're going to do an IUI is how many cycles should we do? And this is another study. This one is from 2002. It's very, very well, not that very well, but 20 years ago, where it showed that the cumulative pregnancy rate per cycle increases, especially in the 3 first cycles. After those 3, the 4th, the 5th, and the 6th, then the cumulative pregnancy rate doesn't increase very much. So actually, the guidelines recommend between 3 to 6, but we recommend 3, maximum 4, maximum number of 4, because more than 4, you won't get that patient pregnant. So we recommend that you might choose a different way, maybe to do a laparoscopic surgery to find out about the fallopian tubes. Maybe the fallopian tubes have adhesions or something like that, or maybe you have different type of endometriosis that you were thinking, or in other cases, it would be better to go through the IVF process and not just keep the patient going through the IUI cycles, because the results won't be very good. And maybe this is the most important recommendation that I would give you, is that you have to manage the patient's expectations. Because usually when you think about a treatment for infertility, you think that you will get pregnant on the first try. And especially with IUI, this might not happen. The highest pregnancy rate in IUI are between 15 to 20% per cycle. So actually what you're doing, it's like you're going back through time to put that couple on the first month when they start trying to get pregnant. So you won't get higher pregnancy rates. And the cumulative pregnancy rates usually are not above 40 to 50% with 3 cycles. So actually one thing that you have to tell your patients is that this might help you. But some patients, almost half of the patients after 3 cycles, won't get pregnant. Even with 4, 5, or 6, not more than 55 or 60% will get pregnant. So that's one of my most important recommendations that I would give you. And when to use donated semen for IUI? In 3 cases. Couples where the male factor is azoospermia, women without male couple, or in patients where they have already done an IVF treatment with ICSI and they had a failure due to male factor, but the female factors are normal, then you can go back to IUI with donated semen. I hope that this recommendation helped you a lot in your office. And if you have any other questions, well, I'm here for you. I belong to SER, and it was a pleasure to be with you. Have a good day.